We are live now.
Okay. Good evening, delegates and participants. Thank you for joining Shield Connect. And today we are back with our famous series, Icons in Conversation with Dr. Ritu Santwani ma'am. And today, the icon for the today's topic, Gynecological Cancer in Menopause, will be taken by Professor Fazia Hossain from Bangladesh. So before I start with the session, let me introduce Dr. Ritu Santwani ma'am, who made this webinar possible with Dr. Fazia Hossain. So Dr. Ritu Santwani ma'am has done MBBS, MD, FICOG, FIAOG, AMR, COG. Ma'am is obstetrician and gynecologist, an IVF specialist, and founder and CEO of 360 Degrees Healthcare Studio. Ma'am is also consultant at Inamdar Multi-Speciality Hospital in Pune. Ma'am is infertility test tube baby specialist. Ma'am is also part of NUHS Singapore, co-founder of MAAM, board member of SWWC. Now, let me welcome icon of the day, Professor Fazia Hossain. Ma'am has done FRCOG MS, MRCOG. Ma'am is International Affairs Secretary of OGSB, Vice President of Bangladesh Society for Colposcopy and Cervical Pathology, Department of Gynecological Oncology, and Bangabadhu Sheikh Mujib Medical University. So I welcome Dr. Fazia Hossain, and I will hand over the session to Dr. Ritu ma'am. Thank you so much, ma'am.
Yeah. Thank you, Nishant, and thank you, Shield Connect, for providing the platform for this weekly series. Friends, as we all know that knowledge is not bounded to any one country or any one group. Knowledge always increases by sharing. With this motto, I started this series. Today, we are very lucky, I can say we are honored to have with us Professor Fazia Hossain Madam with us. Thank you, Madam. Thank you so much for joining with us. I know Madam's schedule is very, very busy, though Madam has accepted our invitation. And today, when we are discussing about the program, Madam has only suggested that this topic. So this topic is really a very burning topic. What are the different gynecological cancers in the menopause? We all are aware that the cervical cancer is very high in our India. Besides the cancer of vulva, cancer of vagina. So Madam is going to enlighten with us in all these. So I'm thankful to all other our doctor friends also who have joined all across the geography. So the program is going live on the YouTube. I have already put the link in the chat box session, and again I will share in between also. So without wasting much time, I am handing over the session to Madam Professor Fazia Hossain. Madam, once again a very, very warm welcome to you. In our India we say namaste and aapka tahe dil se swagat hai. Yeah. Over to you, Madam. Yeah.
Thank you, Dr. Ritu Santwani. Assalamu alaikum. A very good evening to the ladies and gentlemen of this August gathering, and namaskar. Thank you very much for inviting me in this prestigious webinar. So I shall be talking about the malignancy, the gynecological malignancy, which are usually encountered in menopausal ladies. So let me share the screen. Is it visible?
Yes, Madam. Yes.
Okay. So that's me. You have already introduced me. I'm working in Bangabandhu Sheikh Mujib Medical University. And apart from being the International Affairs Secretary and Vice President of BDSSCP, I was the Honorary Secretary of the IRC RCG Bangladesh chapter. And I have 30 publications, and I've contributed to many books and guidelines and invited speakers on more than 80 international conferences. Okay, so I bring warm greetings from Bangabandhu Sheikh Mujib Medical University, where I work. Now, let us go to the topic. We all know what is menopause. So it is the transition between a woman's childbearing years and non-childbearing years. And it is the last stage of a gradual biological process that actually begins during the mid-30s. And menopause usually occurs between the ages of 45 and 55 years. and when the menstruation stops for 1 year. We all know what are the effects of menopause on health. Women have mood changes, irritability, sleep disturbances, hot flashes, urinary problems, vaginal dryness, increased heart disease and stroke, and osteoporosis. Common manifestations during menopause. Now, our topic was on gynecological cancers. We all know that gynecological cancers affect 1.3 million people, and the menopausal symptoms often result from the oncologic treatments prematurely. That is, if a woman at a premenopausal age has a bilateral oophorectomy, for example, for ovarian cancer, she has surgical menopause. So the ovarian failure associated with chemotherapy or radiotherapy, which is also another treatment modality of gynecological cancers, that also causes premature menopause. Additionally, with the growing availability of testing for pathogenic gene variants such as BRCA1, BRCA2, and the Lynch syndrome, more women are undergoing the risk-reducing surgeries, that is preventive bilateral salpingo oophorectomy before the age of 45 years. That also induces surgical menopause. Now, what are the other risk factors of cancer during menopause? First of all, nulliparity, early menarche, late menopause, HPV infection, smoking, HIV infection, or a weak immune system, obesity, previous history of breast or gynecologic cancer, older age, family history, use of oral birth control pills or fertility drugs, estrogen therapy, high-fat diet, prior radiation to the pelvic area. Other causes and risk factors include family history of ovarian, uterine, colon, or breast cancer. The postmenopausal state itself is a risk factor. Infertility, first intercourse before the age of 16, having multiple sexual partners, being overweight, being a smoker, having comorbidities such as diabetes and hypertension, not engaging in cervical screening or having persistent human papillomavirus infection, taking tamoxifen, and women who are having unopposed estrogen therapy. The risk of developing cancer increases with age. There are two key factors. One is the increased exposure to estrogen and a higher number of ovulations. In women with late onset menopause, that is when the menopause occurs after the age of 55 years, they develop breast and endometrial cancer more due to a longer exposure to estrogen. Ovarian cancer also occurs due to a higher number of ovulations. The high levels of the biological estrogens during the menstruation, when it is not balanced by progesterone, can result in the increased mitotic activity of the gynecological cells and resulting in a high DNA replication and somatic mutations. And these result in a fixed mutation leading to cancer of the genital tract. Now, the systemic hormone therapy is effective treatment for vasomotor symptoms, we all know, and sometimes the topical vaginal estrogen ointment or therapy is effective for the genitourinary symptoms. The role of hormone receptors is a challenge to the management of menopausal symptoms after cancer, and therefore the menopausal hormone therapy, it is very difficult to navigate. Now, what is menopausal hormone therapy? HRT is a treatment that can reduce symptoms of the menopause by changing hormone levels in the body, and they are the chemical messengers that can affect the growth, fertility, and our mood. During the menopause, the ovaries start to produce less amount of estrogen, and as a result, hot flashes and mood changes begin. These symptoms are very uncomfortable, and HRT can help them to reduce. Now, what are the types of HRT or menopausal hormone therapy? The main types of HRT are estrogen-only HRT, combined HRT, which contains estrogen and progesterone, other forms of HRT like tibolone, and sometimes testosterone is also included in HRT. And they may be available in the form of tablets, injections, patches, vaginal rings, implants, suppositories, and creams. We all know that the benefits of hormone replacement therapy are that it relieves hot flashes, mood swings, improves vaginal dryness, and improves the brain fog or the difficulty in concentrating. And the risks are there is increased risk of having thrombophlebitis, deep vein thrombosis, strokes, breast cancer, endometrial cancers, and gallstones. The common side effects are headaches, nausea, cramping, bloating and indigestion, vaginal discharge or pervaginal spotting, fluid retention, mastalgia, or breast pain. And the risks of long-term use may include DVT or deep vein thrombosis, blood clotting, you call it, liver damage, gallbladder disease, breast, ovarian, or uterine cancer, thyroid disorder, and high blood pressure. The risks of menopausal hormone therapy are that while HRT has potential benefits for many postmenopausal women, it can also have some drawbacks. The concerns about the HRT center on the risk of endometrial cancer and breast cancer, especially after long-term use. Another group of women, as I've mentioned earlier, are the young women affected with gynecological cancer. So this group of women is very important. Also, HRT in women with comorbidities requires more attention. The alternatives of HRT, we all know, are herbal remedies, meditation-based therapy, bioidentical hormone replacement therapy. Now, approximately 21,000 women in the UK are diagnosed with a gynecological malignancy in the postmenopausal women. 30 to 40% are present in the premenopausal or perimenopausal women. The management typically involves surgery or chemotherapy or radiotherapy, which in younger women may result in an induced menopause. And as a result, what happens in addition to the treatment and the agony of cancer, they have more symptoms of premature menopause like anxiety, increased anger, weight gain, depression, night sweats, sleep disturbances, mood swings, etc. And therefore, as I've already mentioned, these compromise the quality and quantity of life in addition to the cancer diagnosis and the treatment. These patients present a complex group, and most units, general gynecological units, do not have easy access to menopause specialists in our part of the world. So gynecologists may be reluctant to prescribe hormone replacement therapy to these women. And clinicians involved in the care of these women must appreciate when HRT should be given and when it is not contraindicated. Now, should we take MHT? So the risk from HRT depends on many different things. This includes the type of HRT, when the woman starts to take it, how long they are going to have it, her age, her general health, and the benefits of taking HRT will vary from person to person too. So everyone is different. And so we have to talk about the options of the availability. It is also important to remember that there are other things that affect cancer risk more than the HRT. For example, one can reduce cancer risk by stopping smoking, keeping a healthy weight, and drinking less alcohol. So only taking HRT does not increase the risk of cancer. So how does HRT compare? Here we can see the cancer risk is small compared to many other risk factors. Like if a woman is not taking HRT or minimizing HRT, that could prevent 1,400 cancer cases per year. While a woman, if she keeps a healthy weight, she could prevent 13,200 cancer cases per year. And women, if they are avoiding smoking or give up smoking, they could prevent 22,000 cancer cases per year. So we cannot blame HRT for all the cancers. Okay, now every 64 minutes, one cancer is diagnosed in the genital tract globally. So according to incidence in our part of in Bangladesh, I would say the highest cancer is breast cancer, then it is cervical cancer, then endometrial cancer, then ovarian cancer. Fourth is endometrial cancer. Lastly, it's vulval and vaginal cancer. But in case of postmenopausal ladies, the incidence of cervical cancer is not the second highest. It goes after ovarian and endometrial cancer. And as I've already mentioned, that in globally breast cancer incidence, it has the highest prevalence in the world and in our country also. Who are the women at risk of developing breast cancer? Women who has early menarche, late menopause, use of estrogen therapy for more than 4 to 10 years, use of estrogen progesterone therapy in more advanced stage, family history of breast cancer, personal history of ovarian and colon cancer. So women with breast cancer usually has a mastectomy and they become psychologically and spiritually depressed, but because previously there were no reconstructive surgeries or breast tissue preserving surgeries available. So that is what happened to women with breast cancer. Now, we have to teach every woman how to screen. We have to instruct them for self-breast examination per month. A careful clinical breast examination should be done by a doctor every 2 years, and routine screening mammography should be done yearly in case of postmenopausal women and perimenopausal women after the age of 40. Now, according to a recent study by researchers at Fred Hutchinson Cancer Center, it is a quite interesting finding, I would say, that women who have experienced hot flushes and other menopause symptoms appear to have a 50% decrease in the risk of developing the most common forms of breast cancer than who have never had these change of life symptoms. So hot flushes is not always should be a problematic or a matter of, irritation for us. Women who have hot flushes have 50% decreased risk of having breast cancer. So does HRT increase the risk of breast cancer? Yes, it does. HRT increases the risk of cancer. And the risk is higher when using combined HRT, which uses both estrogen and progesterone. Vaginal estrogens are not linked to an increased risk of breast cancer, whereas tibolone is. Now, taking HRT for 1 year or less slightly increases breast cancer risk, but the longer the HRT is taken, the greater the risks are. Okay, so HRT before or soon after the menopause may have a bigger risk than those who start HRT later. So women of average weight in developed countries, if they are having 5 years of MHT, starting at the age of 50 years, would increase the breast cancer incidence at ages 50 to 69 years by about 1 in every 50 users. So if she uses estrogen plus intermittent progesterone preparations, her risk is 1 in 70. And if she uses estrogen-only preparations, her risk is 1 in every 200 users. And the corresponding excess from 10 years of MHT would be about twice as great. So the longer we use the MHT or HRT, the increased chance of having breast cancer. It has been shown that postmenopausal women in Western countries, they are ER positive, estrogen receptor positive breast cancers constitute about 3/4 of all breast cancers and death. Postmenopausal estrogenic activity is a strong determinant of the incidence of ER positive breast cancer. So the menopausal hormone therapy use is associated with estrogen receptor positive rather than estrogen receptor negative disease. The breast cancer risks in MHT users are strongly duration dependent, as I've already mentioned and emphasized. In Western countries, there have been about 20 million breast cancers diagnosed since 1990, of which about 1 million are caused by MHT use. Therefore, the conclusion is that no HRT should be taken after breast cancer. HRT can increase the risk of recurrence. It also increases the risk of developing another breast cancer. So next comes ovarian cancer in menopause, which has the second highest incidence. Ovarian cancer can affect women at any age, but it is rare under the age of 30 and more common in women after 65 years. It can start in the ovary, fallopian tube, or peritoneum, and approximately 7,000 women are diagnosed every year. Diagnosis is often delayed because women present with non-specific abdominal symptoms like bloated sensation, hyperacidity, and these can be confused for other conditions like irritable bowel syndrome. This is how ovarian cancer looks like. They are usually bilateral. So there is no national screening program for the prevention of ovarian cancer. The diagnosis is usually done by CT scans and abdominal ultrasounds and doing some tumor markers, where the epithelial ovarian cancer is associated with the increase in CA125, which is a glycoprotein and tumor marker, and other markers may be CA19-9, carcinoembryonic antigen, etc. While alpha-fetoprotein, beta-HCG, LDH, these are raised in case of germ cell ovarian tumor, not in epithelial ovarian tumor. So treatment is with chemotherapy and surgery, including hysterectomy and removing the ovaries, appendix, and the omentum. So women who carry the BRCA1, BRCA2, we call it BRCA1, BRCA2 gene, are at increased risk from developing the disease. And ovarian cancer is known as the most lethal genital system malignancy. Why? Because they present very late. It is also the 5th leading cause of cancer-related deaths in American women. So it can be divided, the epithelial ovarian cancer can be divided into 5 histologic subtypes. Now you might ask, why histology? What does it? What relationship does it have with the histological subtypes? Yes, the types are usually serous, mucinous, endometrial, clear cell tumor, and other type of ovarian cancer. The histologic type of ovarian cancer may have different protective factors or pathogenic factors. Breastfeeding and oral contraceptives are confirmed as protective factors in ovarian cancer. In fact, OCP is the only chemoprevention in case of ovarian cancer. While obesity, diabetes, family history of breast and ovarian cancer are demonstrated risk factors for ovarian cancer. The link between ovarian cancer and tibolone remains unclear, and when HRT is stopped, the risk starts to go back to what it would have been if HRT wasn't taken. And yes, both estrogen only and combined HRT slightly increase the risk of ovarian cancer. Some meta-analysis suggested that menopausal HRT may increase the risk of ovarian cancer for serous and endometrial tumors. This finding requires confirmation by further studies. Now, can HRT be prescribed if a woman was treated for ovarian cancer? Yes, recent research studies have concluded that HRT may improve survival for women with ovarian cancer, which was published in the Journal of Clinical Oncology. So women with severe menopausal symptoms after ovarian cancer treatment can safely take HRT, and this may, in fact, infer the benefits in terms of overall survival in addition to advantages in quality of life. So where do we stand? To treat or not to treat with menopausal hormone therapy? Well, the oncologists feel comfortable offering patients HRT after the treatment of epithelial ovarian cancer to reduce vasomotor and other postmenopausal symptoms. Improved quality of life for patients with epithelial ovarian cancer has been demonstrated. Next comes the endometrial cancer, or cancer of the womb. It is rare in women under the age of 40 and becomes more common after the age of 55. Approximately 9,200 women are diagnosed annually. At least 1 in 3 cancers may be caused by obesity and lack of exercise. So we see that that lifestyle behavior has a lot of impact on the development of cancer. Other causes include exposure to estrogen and a rare genetic condition called Lynch syndrome. The most common symptom is irregular vaginal bleeding and postmenopausal bleeding. The diagnosis includes endometrial sampling or fractional curettage, which includes biopsy of the endometrium and endocervical tissue. And we can also do abdominal ultrasound and CT scans. Treatment includes hysterectomy and removal of ovary, external peak, pelvic radiotherapy, and internal brachytherapy may be required in advanced endometrial carcinoma. There is no national screening program for the prevention of endometrial cancer. Again, so endometrial cancer, which usually affects the fundus mostly. The risk of, now, does MHT increase the risk of endometrial cancer? Yes, it does. The risk of endometrial cancer depends on the type of HRT. Estrogen-only HRT increases the risk. The longer this type of HRT is used, the greater is the risk. Estrogen-only HRT is only offered to those who have had a hysterectomy, as they have no risk of endometrial cancer to begin with. Combined HRT can reduce the risk, but combined treatment causes the biggest increase in breast cancer risk. So there is a dilemma again. So similar to estrogen-only HRT, Tibolone also increases the risk. So postmenopausal women on HRT containing estrogen alone are at increased risk of developing endometrial cancer. So to minimize this risk, many HRT users who have not had a hysterectomy use combined estrogen-progestogen preparations or Tibolone. And generally after hysterectomy, at least for patients with cardiovascular risk factors, the preference today is to use a low-dose estrogen therapy in the form of patches or gels instead of the continuous combined HRT. And this is also now recommended for patients after endometrial cancer. So is a HRT protective against endometrial cancer? So two studies were done, and it examined the risk of endometrial cancer in those taking HRT and the advantage of cyclical progestogen therapy in reducing the risk. Both studies found that the progestogen needs to be taken for at least 10 days per cycle for it to provide protection against the risk of endometrial cancer. In addition to progestogen to estrogen in combined HRT, it provides protection for the endometrium against the potential adverse effects of estrogen alone and reduces the risk of developing ovarian endometrial cancer. Sometimes, now let's come to cervical cancer and menopause. It usually occurs in younger women, but it can be, present itself in the postmenopausal state also. Cervical cancer is the most common gynecological cancer. The persistent HPV infection is more common in postmenopausal women. HPV vaccination has no role in primary cervical cancer prevention, so remaining is the screening. So this is a diagram showing the colocytes, the HPV infected cells, where we can see the colocytosis, and the nuclear cytoplasmic ratio has been altered or increased in case of cancer cells. Now, this is the diagram of a normal cervix. This is the cervix, which is infected by human papillomavirus. And when the HPV causes cervical intraepithelial neoplasia, low grade or high grade, this is how it looks like acido-whiteness and mosaics and punctations in the transitional zone of the cervix, transformation zone of the cervix. And this is what the early invasive cervical cancer looks like. Now, coming to the screening, women have to screen themselves with either HPV DNA or pap smear. But pap smear may provide false negative results as the cervix is flushed with the vagina in case of postmenopausal ladies. Therefore, IR spatula scraping and endocervical brush should be used for screening in postmenopausal and perimenopausal ladies. Cervical cancer symptoms in postmenopausal women are non-specific and related with comorbidities. As a result, each sign of cervical cancer in a postmenopausal woman should be investigated thoroughly, like irregular pervaginal bleeding, postmenopausal bleeding, postcoital bleeding. These are the signs which has to be diagnosed carefully, whether it is due to cervical cancer or it is due to endometrial cancer, because the modalities of treatment are totally different in these two cancers. Each year, more than 8,200 women are diagnosed with cervical cancer in Bangladesh. It can affect women at any age. There are two main types of cervical cancer we all know, whereas squamous cell carcinoma is the most prevalent one, but adenocarcinoma also occurs. The main risk factor is infection from HPV, human papillomavirus, and the risk factors also include a weak immune system caused by conditions such as HIV and smoking. Symptoms include abnormal vaginal bleeding, malodorous discharge, and lower back pain. So diagnosis is made by a biopsy from the cervix, MRI, CT, and sometimes PET scan may be done. Early stage cancers are treated with a large loop excision of the transformation zone, or commonly we call it leads or lead, and needle excision of the transformation zone and cone biopsy. And more advanced cancers are treated with surgery. We do radical hysterectomy in case of up to stage 2A, and sometimes chemotherapy and radiotherapy. Radiotherapy can be given in all stages of cervical cancer. So there is a national screening program to detect precancerous changes to the cervix, which can treat abnormalities at an early stage. There is a reduced risk of developing cervical squamous cell carcinoma in postmenopausal women treated with HRT. Studies have shown that. But there is a weak increase in the incidence of adenocarcinoma of cervix. It has been noted. So is HRT contraindicated in cervical cancer? No, there is little risk in giving HRT to women who have had breast or endometrial cancer. No data to suggest that HRT is contraindicated in women who have been treated for cervical or ovarian cancer. Coming to vulvar and vaginal cancer. Cancer of the vulva is rare, with 1,300 diagnosed cases per year. It is most common in women over the age of 65, and only 15% develop vulval cancer under the age of 50 years. The usual site is the inner edges of the labia majora and any part of the labia minora. Squamous cell cancer constitutes about 90% of all the vulval cancers. Other types of cancers include vulval melanoma, basal cell carcinoma, sarcoma, adenocarcinoma, and Bartholin's gland cancer. In older women, vulval cancer is linked with a skin condition called lichen sclerosis and lichen planus and Page's disease. It is also linked to HPV and a precancerous condition called vulval intraepithelial neoplasia. Smoking, a reduced immune system, and coexistence of cervical intraepithelial neoplasia increase the risk of diagnosis. Symptoms include vulval burning, soreness, ulcerated areas, bleeding, moles, lumps in the groin, pain passing urine. Diagnosis is through visual inspection of the area, taking biopsy, CT, and MRI for staging. Treatment is with surgery, chemotherapy, and radiotherapy. So in case of vulval cancer, we can give HMHT. Estrogen use after the menopause is not associated with vulval intraepithelial neoplasia or vulval cancer. There is no relevant information available about any correlation between HRT and these types of cancer. I would like to emphasize about the gynecological oncology specialist team. Actually, we do not work alone. I mean the gynecological oncologists. We work with the surgical oncologists, the urologists, the vascular surgeons, the histopathology team. So we have a tumor board, the multidisciplinary team, where we actually discuss the woman's treatment modalities, her follow-up, and other things. So a gynecological oncology specialist team is very important to ensure continuity of care, support women following their cancer diagnosis, and throughout their treatment and beyond, they can support women. They can ensure high quality, compassionate care, relaying information to assist with informed decision-making around the treatment. Referral to specialist clinics has shown positive impact on patient outcomes, satisfaction, access to care, and cost effectiveness. And they should be empowered to be involved in clinical decisions, initiate and lead discussions within the gynecology multidisciplinary team. And we also have to make them aware about the cancers that can occur during menopause, and we have to make them aware about leading a healthy menopause. So we have to make the women aware that menopause is a phase of transition. It is not a diseased condition. So they have to visit their doctors regularly, try to live a healthy lifestyle as possible, maintain regular exercise routines, restrain intake of caffeine, sugar, salt, and alcohol, avoid smoking, eat foods containing adequate amounts of calcium, vitamin D, low-fat, well-balanced diet, maintain a regular and sufficient sleep schedule, take short-term hormone therapy if needed, proactively manage menopause and use it as an opportunity to prevent disease and improve long-term health and quality of life. And we have to make them aware of the alarming symptoms, which may be abnormal vaginal bleeding, pelvic or abdominal pain, unusual digestive symptoms, blood in the feces, urine, breast abnormalities, unusual cough, venous thromboembolism, etc. Now, the take-home message. Women in the middle age and beyond should be careful about the symptoms of cancer, which I've tried to describe briefly. Treating the effects of menopause in women with history of estrogen-dependent cancer represents a clinical dilemma. Endocrine adjuvant agents like tamoxifen and other cancer treatments often induce premature menopause. Vasomotor, psychological, and somatic symptoms may be more severe in these women. The risk of hormone therapy and its efficacy must be balanced. Currently, there are no consensus guidelines for the management of these patients, and each woman must be individualized regarding the management, and we have to give them all the options. And briefly, I'm talking about breast cancer. No HRT, as it increases the risk of recurrence. It also increases the risk of developing another breast cancer. But vaginal rings or patches may be used to decrease the acute symptoms of menopause. In case of ovarian cancer, they can be safely given HRT, and improved quality of life for patients with epithelial ovarian cancer has been demonstrated as a result of some research studies. In case of endometrial cancer, estrogen-only HRT is only offered to those who have had a hysterectomy, and combined HRT can reduce risk, but combined treatment causes increase in breast cancer. So we have to balance the possible benefits and risk, and again, individualize the woman. And similar to estrogen-only HRT, Tibolone also increases the risk. And in case of cervical, vulvar, or vaginal cancer, these are not, MHT is not contraindicated, not associated with increased vulval intraepithelial neoplasia, vulval, or vaginal cancer. So these are my references. So for women, actually, just 1 second. As you can see, that they are all depressed, you know, that I have shown. So the courage, strength, and determination, this is what is made up of cancer warriors, fighters, survivors, and caregivers. At times, the fight can become tough. We have to strive for the light at the end of the tunnel, and life is full of hope. And then comes the beautiful ladies. So it cannot cripple the love. What cancer cannot do? It cannot cripple the love, shatter faith, or destroy peace. It cannot kill friendship or suppress memories. It is the silent courage that cannot invade the soul, nor can it steal the eternal life or conquer the spirit. So all the women with cancer, we have to be a support system for them. So that was all regarding gynecological cancer and malignancy. So at the end of my session, I would like to thank Dr. Ritu Santwani, who is he's a very good friend of our Bangladeshi OBGYN specialists, and to our women also, because many general people also listen to your YouTube channels, and you are an emblem of knowledge sharing. Dr. Ritu Santwani, I want to thank you once again on behalf of Obstetrical and Gynecological Society of Bangladesh and Bangabandhu Sheikh Mujib Medical University, the faculty, and on behalf of the students. I want to thank you from the core of my heart, and thank you. So this is my Bangladesh.
Thank you, madam. Yeah.
Bangladeshi ladies.
Thank you, madam. Thank you for such an awesome presentation. In such a short time span, you have covered each and everything. Ma'am, if I will get some opportunity, I will definitely like to call you in person, especially in Pune, for a talk. Such a wonderful lecture you have taken, madam. Each and every aspect covered. So, madam, we are for this webinar. A lot of doctors have joined from not only from India and Bangladesh, but from the other countries also. My chat box is full from the appreciation. Some doctors have joined from the Africa and from the Egypt also.
Oh, really? Thank you.
Yeah, madam, all has appreciated. Dr. Nishant, can you check any questions on that? I'm not able to see any questions in between. Yeah.
No,
Madam,
we cannot see any questions in
Okay.
chat box. Participants, if you have any question, please post your question in chat box.
Yeah. So, madam, as you know, this series name, The Icon in Conversation with Dr. Ritu. So now we have finished the one round of the academic portion. Now I'm going to ask some questions which you have to answer in one word without taking much time. These are the general questions. So this is a surprise round, ma'am. This is the surprise round. I never tell anyone, any of the faculty.
Okay.
So, ma'am, yeah. Ma'am, which is your favorite color?
My favorite color, it's pink.
Yes, pink. Okay. Which is your favorite fruit? Madam, you're muted.
Orange. No, I'm not muted.
Okay.
Favorite fruit is orange.
Okay. Okay. So, madam, is it your dream to become a gynecologist since childhood?
No, I never wanted to be a doctor.
Okay.
I never wanted to be a doctor because I wanted to be in the civil service, because as a young student in school and college, I used to do debate. I was very outspoken and I hated doctors because they were studying all the time. I never liked medical students. But my father, my grandfather, my father, there are 8 siblings and none of them became doctors. They were all civil service holders, engineers, chartered accountants, etc. And my grandfather had a dream that one of his child should be a doctor. So when I appeared in the exams after my HSC, that is the equivalent to A-level, then I got chance in Cervical Medical College Hospital. Then I decided, somehow when I went to the premises, I fell in love with the medical college, which is standing by the river of Buriganga, at the side of the Buriganga River. So I liked the campus and the garden. And then I thought, maybe if I become a doctor, my dad will be happy. And it was just a sudden decision, and I became a doctor. And yes, till date, I've been a doctor for 34 years. I don't study the books every day. I can't. I listen very carefully. I study 1 or 2 days. Textbooks, I mean, as a student. But now I read for other reasons, as being a teacher. And I love being a gynecologist because we can touch the hearts of women, and the women in hard to reach areas, the downtrodden women, they are my focus actually. I feel more comfortable in, giving social service to this group of women.
Great, great. Madam, you are role model for many of us. So many doctors are looking at you and want to become like Professor Fawzia. Madam, your any message for the upcoming young doctors?
Well, it sounds very nice that you said that everyone wants to be like Dr. Fawzia. No, my life would be successful when my students are a better performer than myself, in terms of academics, in terms of operative things, of the social activities, research. When you surpass my level, only then my life as a teacher will be successful. So I wish all my students, and it is actually your dedication towards work. If you love your profession, I take it as my passion. The studies, the work, I'm usually multitask. Majority of us are. So if we love our profession, then you don't feel exhausted or tired or depressed. I think all the doctors, especially the gynecologists, are a special species in the world who work and study to the last breath of their lives. I think.
Very true, very true, very true. So thank you so much, madam. Madam, the lecture was self-explanatory. Till now, we have not received any questions. So I'm thankful to you again for giving your precious time to us and sharing your immense knowledge with us. So with this, friends, we will wind up for the day. Stay tuned with us Stay tuned with us next Thursday, same time, 8:30 p.m. Indian Standard Time. We are having another very important lecture, how to deal with the ART pregnancy. What are the pros and cons? So till then, bye-bye, good night, and in advance, happy Diwali to all of you.
Happy Diwali, ma'am.
Happy Diwali and have a great weekend. Thank you very much. Assalamu alaikum.
Thank you, madam. Yeah, bye-bye.